Hi, it's Dr. Daly, and this is a brief protocol update for 2025 for the Remo and ARAMS regions. As we start, I'd like to thank Beth McGowan from Remo for writing the core elements of this brief training, Jeremy Cushman and the staff from Monroe Livingston EMS for guiding our group forward, Chris Fulligar from Syracuse for his leadership as he chairs the Collaborative Protocol Committee, and my wife, Robin Snyder-Daly, for the protocol design many years ago. For every clinician, it's really important to remember protocols are not a substitute for good clinical judgment. If your protocols and the patient in front of you do not coincide, please call a physician for consultation so we make the right decision for each patient. We're going to have a concrete protocol update schedule where new protocols will be in place every July 1st. We welcome input on new protocols and changes to the addition to the existing protocols, and recommend that you look at the links on the regional website, in our case, remo-ems.com. Click on that, add your suggestions to the red cap form. We want your input because these are your protocols. There are global changes, there always will be. It's really important to remember the double plus symbol refers to if equipped and trained. Not all medications and modalities will be implemented by every agency for a lot of different reasons. But when this symbol is there, that means it is not required for an agency to have this. The P in a circle refers to paramedic only. As we continue to advance medicine, there will be more and more interventions and medications that are only accessible to paramedics. And we've also added supraglottic airways to the EMT scope of practice, all the way down to the pediatric level. Again, if the agency is equipped and trained, and in this case must be regionally approved. Let's start by talking about cardiac arrest. We've made a few changes here. Among the things that's really important to consider is a vector change if there's a refractory shockable rhythm. A refractory shockable rhythm means that you have shocked that patient at least 3 times and the patient remains in ventricular fibrillation or pulseless VTAC. If that occurs, you're going to change the vector of electricity going from one pad to the other pad. Here's an example that comes from Zoll, although this can be used with any of the defibrillation devices that we currently use in New York. This is fine for a Stryker device. This is fine for a Philips device. So here's the appearance of an anterior lateral placement of the pad, as well as for the anterior posterior. You'll find very frequently that people who place automatic external defibrillators will place them according to the diagram on the pads themselves, which will lead to anterior lateral placement. If you move those pads to anterior posterior, you'll be more likely to interact, the electricity to interact with more of the left ventricle, and you'll have more potential to reverse the rhythm that the patient is in and hopefully save that life. Make this change if the patient has been defibrillated 3 times or more. Other changes in the extremis cardiac arrest protocols include epinephrine dosing being maxed at 5. We know that almost nobody survives a cardiac arrest if they get more than 5 epinephrines. Therefore, we have limited the dosing to 5. That said, if you have an individual patient contact that you believe would benefit from additional epinephrine, please call for medical consultation, and that physician may order additional epinephrine. For patients in ventricular fibrillation or pulseless ventricular tachycardia, you may use either amiodarone or lidocaine. This is really important, particularly given recent medication shortages of amiodarone. But each cardiologist will have a different idea of what they prefer, and your agencies may choose one over the other. For return of spontaneous circulation, either amiodarone or lidocaine may be given as a medical control option. Remember, if you get return of spontaneous circulation, amio or lidocaine drip is a medical control option. One thing that we've realized is that many patients do get sodium bicarbonate in cardiac arrest. And we clarify in the protocols here that patients should only get sodium bicarb in cardiac arrest if they are believed to be or known to be hyperkalemic, so high potassium, or if they are an agitated patient that went into cardiac arrest. Every patient who goes into cardiac arrest will have some type of acidosis. Sodium bicarb is for reversal of acidosis that caused arrest or hyperkalemia that caused arrest, not for patients who become acidotic because they are in cardiac arrest. So please don't empirically give sodium bicarb to every patient in cardiac arrest. As we said earlier, supraglottic airways may be used in cardiac arrest all the way to the EMT level. This is now approved for adults and pediatrics. But very importantly, this is not a requirement for basic life support agencies in New York State. There's a significant expense associated with waveform capnography. So if the agency does not have waveform capnography, is not approved by the region, they may not use this. This is an equipped and trained intervention. Important for our paramedic and advanced EMT colleagues, every patient that has a supraglottic airway placed should be on waveform capnography to clarify and assure that indeed that patient has adequate gas exchange through that airway device. Atrovent or ipratropium has been added to every level from EMT and higher as either duo-neb or individual mixture of Atrovent and albuterol. This is for anaphylaxis and allergic reactions, COPD and asthma, as well as for pediatric asthma. For the adult pulmonary edema protocol, the advanced EMT may now administer stacked sublingual nitroglycerin. But push dose IV nitroglycerin remains paramedic only if equipped and trained. No nitroglycerin should ever be administered intravenously other than push dose IV unless it's an interfacility move and the patient is on a pump. We should never be hanging a nitro drip pre-hospitally. We've changed the behavioral agitated patient for adult and adolescent patients and added olanzapine or Zyprexa in place of haloperidol. This really is reflecting hospital practice because hospital practice is pretty specific and using Zyprexa in place of Haldol because it has significant amount of fewer side effects. It does still have the potential to increase the QT. It can still profoundly sedate. And if you talk to a physician and use a benzodiazepine as well, then you should watch out for sedation and make sure to monitor that patient's end-tidal CO2. This is a single dose, either IM or sublingual, and there is no repeat. Our oral glucose replenishment for hypoglycemic patients, we clarified the dose is 15 to 30 grams, and we were a little tongue-in-cheek copying our colleagues in Vermont, adding this alternative sugar option of New York maple syrup, noting that Vermont is very specific for their state maple syrup as well. Tranexamic acid, or TXA, has been changed in dose to 2 grams to reflect the current military literature. This is given intravenously or intraosseously over 10 minutes. As a reminder, you should never remain on scene to gain vascular access in order to administer TXA, but you should be moving towards the hospital if you have a patient in hemorrhagic shock. This is a new name for a protocol previously known as trauma-associated shock, because we very clearly recognize that there are both GI as well as obstetric and gynecologic causes of severe hemorrhagic shock. We want to make sure that we can care for all of them using this protocol. We clarify that antibiotics may be used for amputation as well as musculoskeletal trauma and open fractures. Very clearly, IV antibiotics are a great idea for open fractures. Amputation is really an open fracture in most cases, which is why we added this. We also add pediatric dosing for cefazolin. Notably, moxifloxacin PO is for adult use only. It's not approved for all agencies. In fact, there's only one agency that's currently approved to use it in New York State. Agencies must apply to their REMAC to carry oral antibiotics, and in most cases, it won't be something that is a particularly good addition to your armamentarium. Oxygen administration and airway management is clarified to suggest that you use a PEEP valve anytime you're using a BVM, and you can titrate if you need it for ventilatory support and bring PEEP up from 5 centimeters of water all the way up to 10 centimeters of water. If you believe that your patient would benefit from more than 10 centimeters of water of PEEP, then call medical control and have a consultation to discuss that intervention. Do remember, as you increase PEEP, you're increasing your intrathoracic pressure, decreasing venous return to the heart, and you've got to make sure that that mean arterial pressure is maintained of greater than 65, because it will decrease vascular return to the heart. Heat emergencies are also clarified, and we reinforce that emergent cold water immersion is the absolute best treatment for any patient with heat-related altered mental status. So if you get a patient that you suspect has profound heat stroke and has significant altered mental status, please make sure cold water immersion right then and there rather than rapid transport to the hospital, because that's going to be the best care for those patients. For patients with slightly milder heat-related emergencies, you may use the palms and soles of the feet as additional locations for cold pack placement. And personally, I recommend the use of ice rather than just chemical cold packs, because you'll get more effect for longer periods of time. Do watch to make sure that you don't have any local tissue damage while you're chilling the patient. As I mentioned earlier, this is a brief protocol update. I suggest that everybody go and review the New York State Collaborative Protocols that are available on the Department of Health Bureau of EMS website. This is a fantastic document, and everybody should review this regularly to assure that you're providing care as appropriate from the Collaborative Committee and the State Emergency Medical Advisory Committee. Thank you all for taking the time to listen. Be safe.